we did a session on acetabular fractures about 2 weeks ago, and many people said it was fine and useful, but I also had some feedback asking for something far simpler and basic. So this is my version of simple, basic, and we can do another session if it's still not right in some way, or if there's still a different way that people want to look at things. But this is my version of simple and basic. And also it generated for some people real existentialist questions like, what is the acetabulum? What is it for? You know, what is its purpose in the universe? Say again? Somebody's trying to speak, but I can't hear. There's also the option to write something in the chat window if your audio isn't working. Okay, so this is basic acetabulum. So we talked about the anterior and posterior columns of the acetabulum before, and one question people have come up with is, what is the function of each column? How do they differ? And how do fractures of the acetabulum of each column, what is the significance? And is a posterior column fracture equivalent to anterior column fracture? Is a posterior wall fracture equivalent to an anterior wall fracture? And these are really important questions that will raise some really important points. And I think the mechanics of how the acetabulum works is, it was really simplistically described by Le Tournelle in a way that still applies today, as the acetabulum being as an inverted Y with dense condensations of bone forming the posterior and anterior columns, and the acetabulum sitting in between. The function of the columns is for weight transfer to the axial skeleton, and the acetabulum obviously forms the socket for the articulation of the hip joint. So the differences between can anybody suggest some differences between the anterior and posterior columns in terms of anything really, structure, function, relevance? If we have a fracture that divides the posterior column completely or anterior column completely, what are the main differences between them, and what are the implications for the patient? Maybe we'll talk about some cases, and then that will become a little clearer. But I thought it was good just to remember Le Tournelle's two-column principle as applied to the acetabulum. Okay, so we talked last week about the two columns, and so if we look at the hemipelvis from the back, remember we've got ilium, ischium, pubis. And the anterior column is a much more extensive structure, extending over most of the ilium and running into the pubis. And the posterior column, a much more limited structure. But where is the strongest bone? Does anyone have an answer for that? Out of all of this, where there's some parts of the hemipelvis where the bone is quite cancellous and relatively weak. And there is one particular part of the acetabulum where the bone is really, near the acetabulum, where the bone is really dense and strong. And that is really the sciatic buttress here. So this is part of the posterior column. This has got extremely dense bone and actually extends all the way probably to here. And then the back of the ilium here, this bone is not strong. This bone is relatively weak. So here is a channel of bone that is really dense and strong and excellent for screw fixation. Okay, what are these lines? Does anybody know there are lots of lines here that mark the mark the particular landmarks in the acetabulum and pelvis? Does anybody?
Iliopectineal, ilioischial,
Yeah.
the dome, anterior,
Yeah.
posterior wall.
Yes.
And
the medial teardrop.
Yes.
teardrop,
Excellent. Yeah. Well done, Dimitri. And I think maybe Sanish is talking there too.
Yes, I am.
Yes. So yeah, absolutely. So those are the Turnell's lines that demarcate the borders of the acetabulum. And as you can see, the lines are, so, you know, this isn't the acetabulum, this is the brim of the pelvis, the iliopectineal line. But why do we talk about this in relation to the acetabulum? It actually runs over half of the heavy pelvis, but why is it relevant for the acetabulum?
It represents the anterior column.
Exactly. So, so it's an extensive line, but extremely relevant for looking at the anterior column. Okay, so iliopectineal line, as Dimitri says, and Nick has told us, it represents the anterior column, and so we know if that's disrupted, then the anterior column of the acetabulum is disrupted. And so these are lines that we see on a plain X-ray. And one caveat to knowing these lines, I think, help with the understanding of the anatomy of the acetabulum. But in the context of major trauma, which is what most of these patients are, often we don't have a plain X-ray. We only have a CT scan. But understanding what these lines mean and how the columns and walls relate to each other will help us in our interpretation of the CT, which we're going to do as well. Okay, so remember the iliopectineal line represents the anterior column, and it's basically this. So as we look at the plain X-ray, we see lines that are, these lines are a condensation of dense cortical bone. So if you take a pelvis stripped of its muscles and look at it from the front, you won't see this line here. These lines are the superimposition of various shadows of cortical bone. And that's why they're useful in the interpretation of the complex anatomy of the acetabulum. And so, so that's the this edge of the anterior column is seen as the iliopectineal line on a plain X-ray. Okay, ilioischial line, as Dimitri says, represents what?
The posterior column.
Posterior column, great. And so, so one way of really easily remembering these things are the symphysis here, which forms part of the ilioinguinal line, is obviously on the front. If we all have a pelvis, so on the front of the pelvis, you'll feel your symphysis on the front, anteriorly, anterior column. Your seat bone, which you sit on, that's where the ischium is, and the ilioischial line represents the posterior column. And so if we look at the rotating pelvis, then this is the line we're looking at here. And it's that superimposition of that with the ilium lying over it here, sorry, like this, is what we see as the ilioischial line. Does that make sense to people?
Yeah, thank you very
Yes,
much.
thanks. That's great.
Okay. So I'm just seeing somebody's writing something in the chat. Yes. Okay. Fabulous. So Sanesh told us the teardrop represents the medial wall of the acetabulum. And so remember, Latourneuil's classification talks about columns and walls. So if the teardrop is broken through, we just have to think about how that fits in the classification. it's typically a feature. So one limitation of Le Tournelle is it describes common injury patterns, but one limitation is that it doesn't really describe the entity of an osteoporotic fracture, which has particular features, including medial wall comminution and medialization of the femoral head. And so when we see that, those are typically features of fragility fractures of the acetabulum. And so sometimes you'll see the teardrop as being divided in two, which suggests a vertical fracture line passing through the medial wall. So that's also something to look out for. And then the roof, which can be seen by the line drawn here. The anterior rim. So in Le Tournelle's original description, the terminology was lip or rim, which so wall is a flat structure covering the femoral head, whereas lip or rim, those are the correct names for the radiographic lines representing the anterior column. And there's a tip here. It can be very difficult. If you look on the other side, where is it? There's a line here, there's a line here, which is anterior, which is posterior. And so one tip is to start in the superior ramus, which is part of the anterior column, the lower border of the superior ramus, trace it up here. And if we do it on the other side, we can see it runs into something there. Okay, so we think that is anterior column, anterior wall, anterior lip, anterior rim, representing the anterior wall. And posterior, if we run up the ischium here, there, see, running into that. So by starting outside the acetabulum and tracing that up, we can differentiate the anterior rim from the posterior rim. Okay. Okay, so what type of fracture is this? Any guesses?
T-type.
T-type, Dimitri, fantastic. I think you're right. You nailed it. Have you seen it before? Or you're just naturally...
Yes.
Okay, so yeah. So the anterior column's broken. The posterior column's broken. The teardrop is split in two. And the roof is split in two. The anterior rim's broken. And the posterior rim's broken. So it's a T-type. Okay, so this fracture that I'm going to show you is not a T-type. This is something else. Oh. So remember last week we were looking at the constant fragment, right, which is here or here. The patient's lying a bit skew-whiff, so we're not seeing the same segment of hemipelvis on each side. But the constant fragment is the part next to the sacroiliac joint, and we can follow it down to see if this is a complete articular or partial articular fracture. And as we follow it down, here it is. And when we see something here, that is usually, is this front or back?
Back. Posterior wall.
Posterior wall, that looks like posterior wall. And very often the posterior wall will be displaced in a cranial direction towards the head. And so before you start seeing the socket on the affected side, you'll see a bit of posterior wall. So if you see something lying outside the normal field, which is here, on the back, that's usually posterior wall. What's this structure? What's this part of the pelvis? This sort of thing sticking out at the front.
Anterior wall.
So this is a really great example because we can see the socket on this side, but because the patient is lying obliquely in the scanner, we can't see the socket. We're above the socket here. And so the anterior wall is part of the socket, but above the socket, you have an anterior column structure that is sticking forwards, which is the anterior, first of all, you have the anterior superior iliac spine, then you have the anterior inferior iliac spine. And just above the acetabulum, it's the anterior inferior iliac spine that you see. Whereas here we've got anterior and posterior wall. Okay, so the constant fragment is coming down here, and still we haven't seen something breaking it away. This is, as Dimitri says, a piece of posterior wall. And this fracture line is running relatively vertical. What does that mean? I mean, vertical, it's running from front to back, almost straight from front to back.
Transverse.
Yes. So Dimitri's like an acetabular expert. I think I should just hand over. When you see a single fracture line running in this orientation, it's usually indicative of a transverse fracture. Okay, so we can see that the fracture line is quite consistent through a number of sequences. Oh. Okay, what's this part here? So really on both sides, you see we can follow
Root of Ramus.
Root of Ramus. Okay, so let's talk about root of Ramus. So this is the ileum, this is constant fragment. As we come down, we see posterior wall, anterior inferior iliac spine, and then, oh, sorry guys. There's ileum, constant fragment, anterior inferior iliac spine, posterior column, anterior column, medial wall. So here we're just coming into dome. Okay, we're just starting to reach the dome of the acetabulum. And then the widest part of the femoral head is about here. Okay, so that's where you see that the widest part of the femoral head is where you see the anterior wall. Posterior wall, oops, posterior wall has been smashed to smithereens. And you saw that. See, we're looking for posterior wall here, and there's only these bits. That's because usually the main piece is displaced more proximally, and that's usually where you see it. So, so don't be confused by that. This is posterior column, anterior column. Okay, so Dimitri was talking about root of Ramus. So remember, your ramus is running like this, and root of Ramus is here. If there's going to be a root of Ramus fracture, it's going to be here. And you see it in this patient as part of the transverse element. This is where the fracture is exiting. So root of Ramus refers to, as we talked about last week, it's an element of a pelvic ring fracture. Often confused with an acetabular fracture because it's so close to the front of the acetabulum. But in this situation, it's part of a bigger fracture line, which is the transverse fracture. You can get caught out with transverse fractures because CT is very good for showing fine detail. CT is very good for showing fine fracture lines. It's not good for giving an overall picture of the orientation of the fracture line if it's not orthogonal to one of these sagittal coronal axial sequences. And so I do tend to look at the 3D image, which I got here for that reason too. So if we look at the coronal now, we're just seeing this is the anterior superior iliac spine, iliac crest coming into view, ramus. Yeah, so if we just go back a little bit. So root of ramus will be about here. And as we look through the scan, sorry, it's on this side, we can see it isn't really like that. There's a fracture running all the way back. And then here, which part of the acetabulum is this?
Posterior column.
Posterior column, and there's a little step in the posterior column, and we're seeing some posterior wall as well. So this is what type of fracture is this?
Transverse.
transverse with
Posterior wall.
transverse posterior wall. Fantastic. And you can see there's lots of pieces of posterior wall. It's not only one piece, and the fracture, the orientation of the fracture line is quite, it starts here and it runs backwards there, and it's running pretty much in the same orientation. Now it's going more distal, so the orientation of the transverse fracture line is quite oblique. Okay. All right, so there you're seeing, this is a great sequence for seeing all these pieces of posterior wall. So, very often on the, particularly on the axial, which is often the first one we look at, the pieces of posterior wall look really thin and small, but here you can see there's quite a big piece. And usually when we look in surgically, we find there's sometimes many pieces, but usually what looks quite small on the scan can be actually quite large, like as you see here, which we see more clearly on this sagittal sequence. So there's another feature of this fracture that we haven't talked about yet. Has anyone spotted it? You can see it on these sequences. There's a transverse posterior wall fracture, but there's something else, part of this fracture, that is going to be a bit of a problem. What can we see there? Does anyone know what this is called? I'm looking particularly here. Particularly here, where you can see there's the joint surface, but then there's something has gone on here, something bad. I know that Johnny knows because he operated on it yesterday, and he did a lovely job where he went all around with an osteotome into the...
Is that the marginal impaction?
Marginal impaction, yeah, Ruben was there too. That's right, marginal impaction is something that you just, unless it's huge and massive, where sometimes in elderly patients, the femoral head can just drive into the acetabulum. So this is a 3D image of what we've just seen. And so in elderly patients, the femoral head drives into the acetabulum. You get a sort of half femoral head's worth of impaction and the seagull sign on a plain X-ray, but with more subtle. So this is actually quite extensive, the marginal impaction on this image. But you don't see it well on this 3D scan. You get an idea of what's going on there. You see it best on the axial CT scan. So maybe we'll go back to that. Ruben, what's the significance of marginal impaction? What does it mean? Does it make a difference to what we do?
I guess it affects the congruity of the acetabulum itself, and you've got to reconstruct it based on the femoral head. Yeah,
so you have normally two congruent surfaces. You have the socket of the acetabulum and the convexity of the femoral head. But when there's marginal impaction, just looking to see where. Okay, there's a good image. So there's the socket, and it should continue round like this. But this has been stoved as the femoral head has rotated outwards. This has been stoved in. And here it looks quite subtle, but as Ruben says, you will, if all you do is lay the wall on and lay plates on, then you will leave the hip joint incongruent, and that is associated with a poor prognosis. I have to say, marginal impaction is associated with a poor prognosis anyway, and so we don't really know if doing this makes any difference, but we believe it does. So what Johnny did yesterday was to put an osteotome in. It goes in the good cancellous bone, just as you would with a plateau or a pilon fracture, and then you lever it up, and we laid in quite a hefty chunk of greater trochanter into the void behind, supporting the elevated marginal impaction. And we had to do that really around the whole posterior margin of the acetabulum for almost the entire circumference that we could see because of the extent of it. Okay, so in terms of fixing the posterior column and posterior wall, you can see here's the posterior column fracture. And so what we found is when we were elevating the marginal impaction, there was nothing to lever against until we fixed this. Until we fixed this, when we were trying to elevate it, this fracture line was just opening. So we realized we had to fix this first. And then fixation of, how do we fix all of these small fragments? So apart from Ruben and Johnny, who were there, Duncan was there too, but I think he's not on the call.
I'm here, but I'm still getting my head around it.
Are you? Okay, so we kept swapping people around so that everybody could get a view. So I know that you saw parts of it, and I know that we put lots of metal in there, and people have seen the images. But there's a particular type of plate that is traditionally used for small posterior wall fragments.
That was the spring plate.
That's right. Yeah. So here the spring plates are There's one, and they buttress down those really small fragments. And because those small fragments are right on the edge of a socket that's very thin, you can't then put a screw in the traditional way right next to it. So we just put a screw into bone outside the socket as close as we can, and that seems to work well. And these are plates that are made by Synthes, rather than in the traditional way we used to manufacture them by breaking off a piece of 1/3 tubular plate. So our strategy was to fix the posterior column, to elevate the marginal impaction, graft it, put in the spring plates to reduce the larger pieces of the posterior wall fracture, fix them with spring plates, and then lay 2 larger plates over, one plate already there for the posterior column, lay 1 additional plate over to hold down the posterior wall and support the spring plates. So what are these views called? There are names for these views that we get in theatre. They show us the acetabulum in profile. They're sort of equivalent to Judo views, aren't they? They're oblique views, taken with an obliquity in the coronal plane. So this is iliac oblique, and the sciatic notch, the greater sciatic notch, is here. The ischial spine is here, and we can see the posterior column. And we can see, one orientation of the acetabulum. And the other view is the obturator oblique. And we can see that the plates are lying down nicely on the ilium. Okay, so we talked last week about Letourneau's classification with the 5 elementary and 5 associated patterns. And we've talked today briefly about osteoporotic fractures, fragility fractures. So one thing I just wanted to show you is when we look at how we're going to address these surgically, it's quite useful to think about posterior approaches and anterior approaches. So with a posterior approach, that's useful for posterior wall and posterior column. Associated fractures, we can transverse posterior wall, which is the example that we've looked at, and posterior column, posterior wall. So if you have a transverse fracture without a posterior wall, in theory you could approach that from the front or the back, but as we discussed last time, the reduction tools and reduction instruments and reduction techniques you can use for a posterior approach to a transverse fracture are more powerful than what can be achieved anteriorly, although that's still a possibility. But when you have an associated posterior wall, then to a displaced posterior wall, then you have to tackle that from the back. Okay, so anterior injuries. Has anybody seen an anterior wall fracture in isolation? They're very unusual. I've only treated it surgically once where a patient had an anterior dislocation and it was recurrently unstable. So that's a really rare thing. And as we discussed before, what's reported on CT scans as an anterior wall fracture is frequently a root of ramus, frequently part of a pelvic ring injury. Okay, and anterior column fractures we've talked about. And associated anterior column posterior hemitransverse, which is a fracture pattern we see more often in older people. And remember, the transverse fracture is the only single fracture line. It's an elementary type of fracture that passes through both columns. And we typically see a front to back orientation of a fracture line on the axial CT. And the T-type is the associated. So we talked last week about ABCs and their features. And we looked at this scan. We looked at these scans before. So here is a CT scan showing marginal impaction really well. Quite a good example. So all of this should be up next to the femoral head, but it isn't. As the femoral head is rotated outwards, it's pushed this like a pestle and mortar back and crunched up this cancellous bone. And so it's important to address that. And there's an intraoperative picture of marginal impaction. So you can see there's the femoral head. It's got acetabulum all up against it. This is where the posterior wall has come off. And here is the edge of the femoral head. And this here, so you've got a bit of chondral surface here and a bit here that's been stowed right in, and that needs to be elevated. So guys, what things affect prognosis? What makes you think, this patient might do badly? We're still going to spend 4 hours fixing them, but things might not go so well for them in a year or two. And there's nobody really in that category for acetabular fractures as a feature of the fracture itself, where we would be nihilistic and say it's not worth doing something. That's not the, we've been trying to do more conservative management since COVID has been a problem, but under normal circumstances, we would manage the majority of displaced acetabular fractures surgically as soon as possible. But what are the features that make you think someone will do worse?
Joint incongruity?
Yeah, absolutely. Yeah. There's a number of features. So yeah, we know that if the joint's incongruent, so a few patients we've treated conservatively have been associated both column fractures, which are complete articular fractures. The whole of the acetabulum is displaced, usually medially, and you have excellent secondary congruence. Okay, so joint incongruity is bad. What else is bad?
Some fracture patterns?
Yes, yeah. So you might think that the worst fracture patterns have the worst prognosis, and there is something about the violence of the injury correlating with worse fracture patterns. But actually, there's one relatively simple fracture pattern that carries a bad prognosis. Does anyone know what that is? So I can tell you it's the posterior wall fracture. So the one we did yesterday was a particularly bad one with quite extensive comminution and marginal impaction. But a really straightforward posterior wall fracture Historically, before we had the major trauma network, it might be somebody who hasn't done it before, who just wants to take it on because it seems like a simple thing. And yet pelvic and acetabular surgeons know that, unfortunately, this fracture is associated with a poor prognosis. What happens? What are the bad things that happen after a posterior wall fracture?
Not reconstruction of marginal impaction and then incongruity.
Yes,
Sciatic
but
nerve injury.
that's say again?
A sciatic nerve injury.
Yes, so sciatic nerve injury. So incongruity and failure to address marginal impaction those are features of having incongruity as a separate thing. With a posterior wall, one of the problems surgically is a sciatic nerve palsy for patients who are managed surgically, which is a dreadful complication that cannot be put right. It may recover, it may not, but you can't undo it. And so that's a devastating complication. What else? There's one other terrible thing that happens.
Hypertrophic ossification.
Yes, yeah. So those are the two main awful things about posterior wall fractures. They cause loss of function and disability. So we have a group of patients with posterior wall fractures who we don't operate on. Who are they?
Patients who already have arthritis.
Yeah, so that's really unusual, Dimitri. We tend not to see posterior wall fractures in that group of patients because it tends to be a relatively high energy injury associated with a hip dislocation. So you're right, in that scenario we wouldn't operate on someone unless, so what I'm getting at is arthritis is not really an indicator of whether we should or operate or not. The main issue is a posterior wall fracture. Is it associated with instability or not? So you can't have people, trying to limp around with a dislocated hip or a subluxed hip. That's not going to be good for them, or even possible. And so what we try and do is establish stability. So all patients with posterior wall fractures should undergo some form of examination under anesthesia, ideally at the time of relocation. So you put the hip back in, and this isn't something you can do if you're in the emergency department. The right thing to do with a dislocated hip is to put it back as soon as possible in the emergency department if that's practical. But then there's a question mark over stability. So sometimes we take a patient to theatre for an examination under anaesthetic just to stress the hip, and if we find it's unstable, we'll then fix it. If we find it is stable, then we won't. But even that is controversial. There are cases described where a hip was found to be stable under anesthesia and then later dislocated. There are case reports of this happening. So I think it probably is a reflection of how the examination under anesthesia is carried out. With, there should be a really, first of all, an assessment of whether it's grossly unstable, and then if it seems stable, really testing it hard to see if it's possible to dislocate the hip. So in patients who have a posterior wall fracture and a stable hip, we don't operate. So that's to try and avoid the complications. Okay, so this is a very large study looking at negative prognostic factors, and you're quite right. Non-anatomical fracture reduction. We didn't talk about age, so older patients. In terms of the survivorship of the hip and whether that hip goes on to need a hip replacement. And people don't die of the displaced acetabular fracture. The consequence is requiring hip replacement, which is not a bad thing, but it's just a sign that things didn't go as well for them as they might have done. Incongruity of the hip, age, anterior hip dislocation is a bad sign because it's rare and it's difficult to treat. Posterior wall impaction, femoral head damage. Okay, femoral head damage. We have a patient we operated on recently who has all of those things. He's over 40. He has a posterior wall, femoral head damage. We fixed him, and it looks like he may need an early hip replacement. What's the extended iliofemoral approach? Has anybody seen that? That's an indicator of poor prognosis in acetabular fractures. And it's basically an approach where you flay open the patient and strip all the muscles off the ilium, front and back. And I don't think it's being done in the UK anymore. I contributed to a survey a few years ago, and I don't think there was any demand for it anymore because of the almost 100% incidence of infection. And now we use other techniques. We're much more likely to use a combined approach where we use limited incisions, utilizing part of a posterior approach and part of an anterior approach. So we're not seeing that dreadful thing anymore. And the fact is that the majority of patients treated where we're able to restore the anatomy of the acetabulum will, and if they don't have the features we talked about, they won't need a hip replacement. So that's really good news. But the most important factor is age. As you can see, the weighting of age is huge compared to the other factors. So to summarize, we can gain a better understanding of the acetabulum by looking at the lines on an X-ray, but CT scan will show you some information that you can't get from an X-ray, including marginal impaction. And loose fragments. If you have fragments in the joint, you may not see them on a plain X-ray, and they can be quite difficult to see intraoperatively as well. You should rely much more on seeing them under direct vision. And the predictors of outcome, we've talked about all of those. So I hope that's made things, I hope that's a more sort of simple take on acetabular fractures, and understanding what the different parts of the CT represent, and a guide to treatment. Does anyone have any questions or points they want to raise?
I think it was a very clear presentation. Thank you.
Okay.
Yeah. Thanks, Homer. That was great. Yeah, thank you.
My pleasure. So I'm just seeing somebody's put something on the chat. So I think I'm recording. Johnny. I know that Johnny is holding back and not saying things because he wants people to contribute. We know he knows all the answers. So I think I'm recording all of these sessions, and so I will upload them probably to YouTube or somewhere at some point. The forthcoming sessions, I've had a request to do a session on hemiarthroplasty, because everybody, particularly for junior registrars, learn everything about DHS for national selection, but hemiarthroplasty is something we tend not to talk about much, and maybe people will have various things they want to contribute about what they find useful, so that would be good. And other topics as well. There's a suggestion that maybe we're going to be seeing mostly trauma in our clinical work for the foreseeable future, but that needn't stop us talking about the theory and examples of other parts of our practice. So just let me know what you want to talk about and we'll do some more sessions. Okay, great. Thanks, everyone. I'll say
thanks very much.
Pleasure.
Thank you very much.
Thanks, Homer.
All right, nice to see you, Johnny.